All right. હું અમારા સેક્રેટરી છે ને એ અને હું સેક્રેટરી ચેરમેન છે એની જોડે વાત કરી કહું બરોબર હા કઈ વાંધો નહીં હું કહી દઉં પેલા કહી દીધું છે એ કહી દે તો મહેન્દ્રભાઈ ના કહી દો પૂછી લે.
Hello. Yeah, I think we are ready to go live. Dr.
Okay.
Sanjay.
Yes.
Yeah, I'll mute everyone. I welcome Dr. Andrea Ferretti, who is from Italy and who has got wonderful work on knee joint, especially the rotary instability of the knee, to speak with us on behalf of Indian the Arthroscopy Study Group as well as Arthroscopy Academy of India. I welcome him on this webinar. We'll be joined by a few panelists. Currently, we have the moderators, Dr. Sanjay Trivedi, Dr. Jaya Prasad, and Dr. Nicholas Antao. And later on, we will have more and more moderator. I'll request Dr. Eduardo Monaco also to welcome. And if possible, he can join with some other system. Either he can be on mobile because we may require him to join for question answers if possible. So without any delay, I'll request Dr. Antao, Dr. Sanjay Trivedi to start the proceedings for the day. I think a program is there with you, Sanjay. So you can start. Sanjay, just a minute. Sanjay, you are mute. Okay.
Right. Good evening, friends. I welcome you all for this exciting webinar by Arthroscopy Academy and Arthroscopy Study Group of India. And I have privilege to welcome Dr. Andrea Ferretti from Italy for his presentation on rotary instability in anterior cruciate ligament reconstruction. And Dr. Ferretti, floor is all yours. Please share your screen and let's begin.
Hey, can you hear me?
Yeah, we can
Very
hear
well.
you.
Okay. Thank you. Dear friends, it's a great pleasure and honor for me being with all of you in a period when, due to the coronavirus outbreak, our daily and professional lives are so badly affected. Let me thank my friend Roshan for this kind invitation and my co-speaker Eduardo, who in the last years shared with me a long-lasting experience on rotatory instability in ACL deficient and reconstructed knee. I am professionally born and grew in this historical building in the center.
Dr. Andrea, you have to share your screen. We can't see your screen. Just open your presentation in desktop.
Yes, I try again. Okay, just a moment.
Yeah.
It's okay now?
Yes, that's much better.
Yeah, we can see it.
Okay.
Yes. You can go ahead. I'll just mute everyone.
Okay. I am professionally born.
Unmute yourself, sir.
It's okay now?
Yeah, we can hear you.
Okay. In this historical building, in the center of the university city in Rome, downtown Rome, in a family of first-class orthopedic and knee surgeons, led by Professor Lamberto Perugia, along with Giancarlo Puddu, who now sits in the Hall of Fame of the American Orthopedic Society for Sports Medicine. Okay. Since the beginning of our scientific interest towards knee surgery, Professor Perugia milestones have been always a careful respect of anatomy. I remember his learning and on any non-anatomical reconstruction is a wrong reconstruction. Use of hamstrings and also use of extra-articular reconstruction whenever needed. In the 2000, I've been called to chair the new orthopedic department at Sant'Andrea University Hospital, the site of the second school of medicine of the La Sapienza University. There, I opened a center of sports injuries named Kirk Kilgour Sports Injury Center after one of my teammates of the Ariccia volleyball club who won the Italian league in 1975. Kirk Kilgour died quadriplegic as a result of a terrible sports injury, volleyball injury. You see in the team, Kirk Kilgour is shirt number 5, I am number 2. And this is the new hospital. Among the pioneers of the knee and ACL surgeons, I would like to quote Riccardo Galeazzi, an Italian surgeon who was the first in Milan to describe a technique of ACL reconstruction with hamstrings. You see, the original drawings I published in the 2003 on the JBJS, a result of an historical research on this technique. However, the beginning of the modern ACL surgery can be dated back to the late 60s, when the rotatory instability and the pivot shift phenomenon were described as a result of an ACL tear. It is well known that the pivot shift phenomenon is a result of a combined of two components, one translational and one rotational. You see, and nowadays the pivot shift test is considered the best way to measure the functional instability, as well as the result of any surgical reconstruction. And reducing or eliminating the pivot shift is now probably the main goal of the ACL reconstruction. Since the 70s and the 80s, some of the pioneers of the ACL surgery recognized that even though the pivot shift test and phenomenon was related to an ACL tear, it was significantly increased by a tear of the so-called secondary restraints. They mainly locate in the anterolateral aspect of the knee. The anatomy of these secondary restraints was investigated by several authors and researchers. Jack Houston, in this very important paper published in 1976 on the Journal of Bone and Joint Surgery, described the so-called middle one-third of the lateral capsular ligament was responsible for the rotational instability in ACL deficient knee. Later on, John Figgin described the thickening of the lateral anterolateral capsule that was responsible for the second fractures in his milestone book, The Crucial Ligaments. Werner Müller in 1982 described the anterolateral femorotibial ligament as a deep portion of the iliotibial tract inserting over the lateral femoral tubercle and inserting distally on the Jerde tubercle. Terry, one of the fellow of Jack Houston and later Vieira, described the horseshoe effect, a combined effect of ACL and anterolateral iliotibial tract to control the internal rotation of the tibia. Stephen Klaes should eventually be credited for his excellent anatomical study and description of the anterolateral ligament of the knee in this very popular paper published on Journal of Anatomy. However, many distinguished researchers questioned about the actual existence of this ligament, and a great debate is still open on this topic. You see among the authors of this paper, Volker Muschel and Freddy Fu, I had several arguments with them about the actual existence of this ligament. In actual fact, in our view, there are several factors supporting the hypothesis that a capsular ligament, such that described by Stephen Klaes, actually exists, as first postulated by Paul Segond in the late 80s, in 19th century. Paul Segond described a marginal fracture on the of the lateral tibial plateau as a result of a pull-out from a poorly resistant fibrous band that became tense in a forced internal rotation of the tibia. Last year, at the American Academy of Orthopedic Surgeon meeting in Las Vegas, we showed a video where the largest series of surgically treated Segond's fracture was presented. In all cases, the iliotibial band, the fascia lata, was normal or only mildly stretched, while the fractures always occurred and was constantly found deeper at the capsular level, just midway between the fibular head and the Jerdy's tubercle, exactly where the site of insertion of the anterolateral ligament was described by Stephen Klaes. I'll show you some cases that were included in this video presented last year at the Academy meeting. This is one case. You see the fascia lata, which is mildly stretched by splitting the fascia lata, which is normally inserted to the Jurdy tubercle, I have access to the deep layer, to the capsular layer, where the second fracture is found, and the bone plug is attached only to the capsular, to the lateral capsule, just at the site of the anterolateral ligament. You see another case, again, the fascia lata is split. This is the lateral meniscus, the white is the lateral meniscus, and this is the fracture. You see? This is another case. The fascia lata is retracted, and the bone plug is attached only to the capsular layer, to the anterolateral ligament. Moreover, whether a careful anatomic dissection is performed, as shown in this video by one of our American fellow, Matt Daggett, the anterolateral ligament can be easily recognized in almost all cases. This is a very accurate dissection of the knee. You can see the anterolateral ligament. This is the same technique described by Stephen Klaes in his very popular paper. And this is the anterolateral ligament. Another factor supporting the actual existence of the anterolateral ligament is the ultrastructural feature of this area, of this capsular area, whose fibers arrangement is comparable with the medial collateral ligament and so much different from the surrounding lateral capsule. So the feature, the ultrastructural electron microscopy feature of the anterolateral ligament is close to that of the medial collateral ligament. This is the medial collateral ligament, and this is the anterolateral ligament. You see, the ultrastructure is quite similar. It is much different from the surrounding capsule. So we agree with the conclusions of this consensus group meeting, which considers that the anterolateral ligament as the most important part of the so-called anterolateral complex, which also includes superficial and deep iliotibial tract, lateral capsule, and posterior horn of the lateral meniscus. In this study, which was published before the classic paper from Stephen Klaes, we investigated the biomechanical role of the anterolateral ligament in a setting of an ACL deficient knee, using a surgical navigator on entire legs instead of amputated knee, as most of the previous similar biomechanical studies. In this study, we perform a tear on the anterolateral capsule, just at the site where we found the second fracture on the in vivo studies. You see, this is a cadaver. And this tear was produced after tearing a sequential tearing of the PL bundle of the ACL, after AM and PL bundle, and after lateral ligament and capsule tear. So we perform a sequential tearing of the PL bundle, AM plus PL bundle, complete ACL tear, and adding an anterolateral ligament tear. As you can see, an explosive pivot shift 3+ was only present when a combined injury was performed. After tearing of the only PL bundle, there was no change in knee stability. It means that the effect on knee stability of isolated tear of the posterolateral bundle is there is no effect. After complete tear of the ACL, in 2 cases over 10 cases, there was no instability, no pivot shift, but only Lachman test. 1+ in 70, only in 1 case we have a 2+. So the effect of a sequential tearing of the ILL is devastating on the stability of the knee, especially on the rotational instability. In this quite similar study, a new software allowing a dynamic evaluation of a pivot shift test, we found that isolated tear of the ACL resulted in an increase of rotational instability in the translational component of the pivot shift, while the cutting the ALL resulted in an increase of the rotational component. I show you. This is the normal knee. There is no instability. The green line, the rotational component of the pivot shift. The yellow line is the translational component. This software allows us to evaluate during the pivot shift the effect of the rotational green and translational components. After complete tearing of the ACL, you see that there is an effect on both component with a higher effect in the green, in the yellow line, than in the green. But after cutting also the ALL, we see a significant increase, especially in the rotational component of the pivot shift. This is a very interesting study performed by Matt Daggett. The black is the anterolateral ligament. You see, in the forced internal rotation, you see that this is stretched and then is torn. This is a very interesting biomechanical study performed in the laboratory of the Matt Daggett in Kansas City. But in actual fact, how often anterolateral ligament and complex injury occur in a setting of an acute ACL tears? In the past, these authors, Hugson, Terry, and Puddu, described up to 100% of prevalence of injuries of anterolateral ligament in a setting of acute ACL tears. This is a study where we collected more than 200 cases of acute ACL injuries collected through a 5-year period, where we found that an ALL involvement was present in about 90% of all cases. We also described the pattern of 4 types of injuries. This is a case where no injuries were found. This is the fascia lata, and then this is the capsule. The capsule is normal, but this is very unusual, occurring in about 10% of all cases of acute ACL tears. The type 1 is probably the less severe injury, is only a stretching of the anterolateral capsule You see stretching with hemorrhage with a normal fascia lata. The type 2 is a more extensive involvement of the anterolateral capsule, also extending towards the posterolateral capsule, below the lateral collateral ligament, which is always normal. You see, it is a wider involvement of the anterolateral capsule. You see, hemorrhagic involvement with the stretching of all the capsule. Sometimes the hemorrhage is present also at the level of the fascia lata, like in this case, with the type 2 involvement. This is another case. Again, the fascia lata, and below the fascia lata, the wide involvement of all the lateral capsule, anterolateral and posterolateral. And this is the retentioning performed with an overlapping suture. Again, another type of 2. Type 2 again, another case. Big involvement, big stretching in the lateral capsule. The type 3 is a complete rupture. It's a complete rupture usually occurring below the lateral meniscus, just above the bony insertion of the anterolateral ligament. You see a complete, you see this is the lateral tibia plateau, this is lateral meniscus, it is a complex rupture. This is another case of complete rupture below the lateral meniscus. Another case of complete rupture. This is the capsule. This is a rupture. Another case, in this case, the injury is visible after the subcutaneous incision. You see the fascia lata with hemorrhage of the fascia lata is complete rupture below the fascia lata at the level of the lateral capsule. The type 4 is a bone injury, the second fracture. You see the second fracture, the bone, in this case, was repaired with anchor sutures. So the second fracture, which is detected in less than 10% of cases, can be considered as a tip of an iceberg of a series of injuries occurring in the mid-substance of the ligament with various degrees of involvement. Another interesting question is whether MRI is able to detect injuries of the anterolateral complex in an acute ACL tear setting. As this area is usually often neglected by radiologists, in order to learn how to read and interpret the images, we perform a study comparing featuring of the feature of affected and non-affected side. As you can see, in the non-affected side, the ALL is clearly visualized in about 95% of cases, while abnormalities were detected in 90% of cases. Besides you see the abnormality was seen in about 90% of cases. And besides the bone bruise that were not considered as a sign of anterolateral ligament involvement, and asymmetry of the genicular vessels were found. You see the non-affected side and the genicular vessels, they are not visible, no more visible in the affected side. And this is one of the more evident feature of the anterolateral ligament involvement, as well as a change in the thickness and in the intensity of the signal of the anterolateral ligament. You see, this is normal, non-affected side, and this is the affected anterolateral ligament. In this study, we compare and we correlate the magnetic resonance imaging with the surgical exploration. And by comparing the changes, MRI changes, surgical feature, we found that MRI is highly sensitive, specific, and accurate in detecting tears of anterolateral ligament and complex, with a high percentage of agreement with surgical findings. However, the pattern of injuries, as described previously by us, is much more difficult to investigate by MRI. So, the MRI is able to detect changes, but is not able to detect the exact amount of involvement. Early in the 60s, extra-articular reconstruction and procedure were very popular, and most of the knee surgeons of that time developed personal techniques, mainly inspired by Lemaire, which was probably the most popular of the surgeons who developed and widespread the lateral reconstructions. In actual fact, the extra-articular reconstructions were supported by three main biomechanical factors. The first is the longer lever arm and the better lever arm of acting on the periphery in controlling rotation rather than acting by the center of the joint in controlling the rotation of the tibia. So it is better and more favorable lever arm. The second factor that support use of extra-articular reconstruction is a sort of protective function on the intra-articular reconstruction, as shown in this very important paper by Egerbrechtsen. He found that by performing an extra-articular reconstruction, by adding an extra-articular reconstruction to an intra-articular reconstruction, the force, the stress on the intra-articular graft can be reduced up to 43%. And this function could be particularly useful in the first period of maturation and incorporation of the graft inside the joint. The third biomechanical factor supporting the extra-articular reconstruction is that they addressed the injury of the so-called secondary restraints, which are so frequently affected along with the ACL tear. I show you some of these historical pictures taken in the old building when I first performed my first knee surgery, ACL surgery. This is the identification of the peroneal nerve, which was required to perform the advancement of the biceps tendon as suggested by Jack Houston. This is the advancement of a biceps tendon on the lateral side. to control internal rotation. And the Jack Houston, in actual fact, suggested also to perform a medial advancement of the semimembranosus tendon along the posterior oblique ligament on the posteromedial aspect of the knee. And this is another step, surgical preparation of the fascia lata reinforced by a PDS band in order to perform a true Lemaire technique. These are historical pictures digitalized with a scanner. And this is the Andrews technique. The Andrews technique, Jimmy Andrews was a fellow of Jack Houston who developed a personal technique to control internal rotation and pivot shift phenomenon to be used along with the intra-articular reconstruction. And this is probably the technique we are still using. Is a modified Macintosh technique as suggested by Arnold and Cocker. This is a very simple technique, very easy and also cheap procedure for lateral reconstruction. And this is the drawing showing the Andrews technique as taken by this Atlas of ACL surgery published in the 80s by our group. However, in the late 80s, in the 1989, the American Orthopedic Society for Sports Medicine organized a consensus conference in Snowmass, in Colorado, is a ski resort, where the experts gather to evaluate the actual efficacy of the extra-articular reconstruction. And they conclude that even if they were biomechanically justified, they were clinically ineffective with a higher rate of complications. Since then, especially in the United States, the surgeons given up using the extra-articular reconstruction, and they focus mainly on the ACL in the bundles, anatomy, and footprints. Also enchanted by the less morbidity of the arthroscopic procedure. In that time, the arthroscopists thought that what is not seen in arthroscopy doesn't matter. On the other side, in Europe, in some center in Europe, surgeons continue using and evaluating the effect of secondary restraints on the rotational instability and pivot shift phenomena. This is a list of papers published by our group dating back to the 80s and the 90s, where we documented our loyalty to the principles of Professor Perugia about anatomical reconstruction, use of hamstrings, and also of extra-articular reconstruction when needed. All these studies were published in the decades when the bone patellar tendon bone reconstruction was considered the gold standard. But why the conclusions of the Snowmass meeting were so misleading? In actual fact, they were based on mainly on bone patellar tendon bone open reconstruction, often followed by a long-lasting post-operative immobilization inflection, and followed also by a very cautious rehabilitation. The final result was often a stiff rather than a stable knee. And we can easily understand then in such a kind of situation, any further additional procedure was, if non-dangerous, useless. But nowadays, taking advantage with the new, less invasive arthroscopy reconstruction, the extensive use of hamstrings, and the principles of accelerated rehabilitation, extra-articular reconstruction are regaining interest among knee surgeons around the world, and an increased number of publications is available in the current literature. This is probably one of the most challenging studies ever performed by our group. We use a surgical navigation intraoperatively with the software, allowing a dynamic evaluation of a pivot shift that was used to evaluate the effect on the pivot shift of intra-articular and extra-articular reconstruction. 20 patients were divided into groups of 10 patients each. In the group A, we perform this is the preoperative evaluation. You see the rotation and the IP translation. And in the group A, we perform the intra-articular reconstruction first and the extra-articular reconstruction thereafter. In the group B, we use the procedure in vice versa order. So before the extra-articular reconstruction and then the intra-articular reconstruction. You see, after ACL reconstruction, we have a quite normal AP translation during pivot shift, but the rotation is mostly non-affected by the intra-articular reconstruction. When we add the extra-articular reconstruction, you see the no more evident rotation. So this is a normal behavior of the knee during the pivot shift, which is negative, no rotation and no translation. The conclusion of this study was that the ACL reconstruction, the lateral tenodesis, are synergistic in controlling the pivot shift phenomenon, being the internal rotation, the intra-articular reconstruction more effective in controlling AP translation, and extra-articular reconstruction more effective in controlling rotation. We use the navigation also to evaluate the double bundle reconstruction and the effect of the double bundle intra-articular reconstruction as compared with the extra-articular tenodesis. This was another very challenging study. And by comparing the effect of the extra-articular reconstruction with the effect of adding a second bundle, the posterolateral bundle, to an anatomic single bundle intra-articular reconstruction, we found that the effect of a lateral tenodesis is statistically more effective. So the extra-articular tenodesis is more effective than adding a second bundle, a PL bundle, in controlling internal rotation. Our long-lasting experience on extra-articular reconstruction was summarized in this recent study published on Arthroscopy, when we evaluate 150 patients after minimum follow-up of 11 years. In 75 patients underwent an ACL reconstruction alone, while 75 patients underwent a combined procedure, intra-articular and extra-articular reconstruction. the two groups were not randomly selected because the extra-articular reconstruction was added only in the higher risk patients. We mean that athletes, adolescents, and women. So, result from the subjective point of view, there is no difference between the two groups because there is no increased pain, no increased stiffness in the group of the combined procedure. But by examining patients from the objective point of view, we found that a statistically significant better result in the group with a combined procedure. Also, the stability in both AP and rotational stability was better in the group with the combined procedure. But probably the most interesting findings were that coming from the radiological evaluation. Because by examining the feature coming from the radiologic evaluation in 2 out of the 3 scales used, we found that in the group with the combined procedure, we had a lower rate of osteoarthritis with less signs of radiological signs of osteoarthritis. This is a very important study. And also in the patellofemoral joints, not only in the femoral tibial joints, but also in the patellofemoral joints. You see, some cases at 15 years follow-up, you see very, very few signs of osteoarthritis. You see, 15 years. This is the other side, this is the affected side. No signs of osteoarthritis. This is another case. Very, very few signs. This is probably the most striking feature coming from this study. And encouraged by our very promising results, we also change a bit our indications for adding an extra-articular reconstruction to an intra-articular reconstruction. In the past, we were using extra-articular reconstruction mainly in case of revision, high-risk athletes, especially female, and in explosive 3+ pivot shift. This is the captain of the Italian football team taking part in the last World Championship. You see the scar showing the lateral reconstruction. And then our actual indications are severe rotational instability, high-risk athletes, and especially females, revision, but also we had hyperlax patients, young patients under 20 years old, and patient with a very, very increased tibial slope. These patients are, in our experience, the most risky patient for failure of the reconstruction. So we conclude that rotational instability in an ACL deficient knee is often a result of a combined injury of ACL and the anterolateral ligament. And the anterolateral ligament actually exists as a capsular ligament and the most important part of the anterolateral complex. Extra-articular reconstructions are either biomechanically and clinically justified. And the use of extra-articular reconstructions along with ACL reconstructions, results in a better outcomes and a lower failure rate with no increased risk of osteoarthritis. There is no risk of overconstraint because even at a long-term follow-up, we have no osteoarthritis and no loss of range of motion, which could be the effect of any kind of overconstraining of the knee. So I finish my presentation. I thank all of you for your kind attention. And if you agree, I give the floor to my colleague and collaborator, Eduardo Monaco. I think that for the question, we can put all the questions together if you agree, but it's not, I mean, it's not to me, it's your decision.
Thank you very much, sir. I think we'll have a few questions right now, and then we can move on to the next lecture.
Yes. So one by one, Dr. Nishith.
Yeah. So excellent presentation, sir. So whatever we are doing now, I think we need to increase more number of lateral reinforcement or lateral reconstruction in our cases, because our patients, they sit on the ground, they sit cross-legged, and they are likely to have more problems when there is a lateral laxity. So am I correct in this view?
Yes, yes, I agree. I fully agree.
Dr. Andrea, can you start your video, Dr. Andrea?
What?
Please start your video. Your screen, there will be a video button.
Ah, yes, yes.
Yeah.
Okay, I'm sorry.
Thank you, Professor. It was fantastic. It was very, very nice. So can I ask you one thing that, sorry, I missed the one thing that when you said the double bundle reconstruction, ACL and ACL with ARL, what was the better outcome was?
You ask whether the effect of the double bundle reconstruction, correct?
Yeah, and
Okay.
ACL and ALL combined. Your study.
So,
Okay, I explain. I try to explain better. Okay, we compare. We start performing an AM anatomic reconstruction.
Right.
Okay, AM anatomic.
Yes.
Then we divided two groups of patients. In
Yes.
one, we had the APL reconstruction.
Mm.
In other group, we had extra-articular reconstruction.
Right.
You understand? So the effect, as evaluated by navigation, the effect of the lateral tenodesis on controlling the tibial rotation was statistically more effective than adding the PL bundle.
Okay.
So if you add the PL bundle to an anatomic AM bundle reconstruction, the effect is very, very small.
Oh.
Little.
Okay.
So, in my opinion, is that the effect of adding the PL bundle is higher.
Right.
Can be seen if you perform a non-anatomic AM bundle.
Okay.
You understand? And by reviewing the
So
history,
is it like transtibial?
it's not anatomic. Whatever the technique you use is not anatomic. If AM bundle is not anatomic, probably you must use a PL bundle to better control rotation. But
Okay.
if you perform an anatomic AM bundle, you don't need to add a second bundle.
Okay.
And I think that the success of the first papers published by Freddie Fu was that he started by adding a PL bundle to a non-anatomic AM bundle.
Okay.
You understand?
Right. Right.
This is my opinion.
Okay.
Because if you perform an anatomic AM bundle, you don't need to add a further PL bundle.
Right.
That's clear?
Yeah.
You understand?
Yes. Yes. And next question. Atik.
So Ferretti, Dr.
Yes, sir,
Pandey,
Sanjay.
if I may ask, when you say that you showed in your presentation that ACL injury is associated with various degrees of ALL injuries. So, at what grade and beyond you recommend to repair this ALL in primary ACL reconstruction?
I think that Eduardo Monaco in the next presentation
Okay,
will
sure,
speak about this.
That's all right.
However, we think that the indication for repair of anterolateral capsule in a setting of acute ACL tear is almost the same of indication of performing an extra-articular reconstruction in chronic cases. You understand? So,
Okay.
it's the same indication.
Which extra-articular reconstruction you prefer?
Eduardo Monaco will show you.
The next talk is about the ALL. So
Yes, about additional procedure.
additional
Eduardo will speak, we describe the surgical techniques. My presentation is mainly focused on philosophy.
philosophy, concept,
Got
and
it.
biomechanics.
You
Yeah,
understand?
it was a wonderful talk, but I just wanted to know when there is you presented a paper in AOS about the avulsion fractures, SIGONs.
Yes.
You compare it the capsular tear, but that is how all the ligaments get avulsed. So does it prove the analogy that the fragment which got damaged or avulsed is the ALL and it's a contributory factor?
Yes. This Paul Segond, if you read the paper of Paul Segond, he described very clearly the mechanism of injury of the Segond fracture, which is a forced internal rotation and a pull out from what he called a fibrous bend of the lateral capsule. He did not identify the anterolateral ligament as later Stephen Kleist, but identify a strong, dense fiber, fibrous band. And he thought that there was a pull out from this dense fibrous band in internal rotation. And you know probably that there are different views about the actual surgical anatomy of the Segond fracture. But in our experience, probably is the largest in the world because nobody published a series of, we have collected 15 cases. In order to collect 15 cases, we spend 4 to 5 years because it's not a very, very frequent injury, the Segond fracture. And in all cases, the fragment was localized, was found midway between the fibular head and the Gerdy tubercle, exactly when the Stephen Kleist, where the Stephen Kleist described the insertion, the distal insertion of the anterolateral ligament. And this is the proof for me that this ligament actually exists. Because if there is a structure strong enough to pull out a bony fragment from the tibia, it must be a ligament. Only a ligament can have the strength, the force to pull out a fragment of bone from its insertion.
Then Andrea, we had a description of anatomy on lateral side of the knee, where people describe the distal capillary fibers, which are attached as a deep part of the IT band, which is getting attachment on the femoral side, as a major cause of explosive pivot. So how do you differentiate these two critical injuries? The one because of this distal Kaplan fiber giving a instability vis-a-vis one which is giving instability because of ALL?
Yeah, this is a very, very good question, because it focuses on the anatomy of the anterolateral aspect of the knee. But in actual fact, the Kaplan fibers belongs to a more superficial part. It's not the capsular layer. The Kaplan fibers insert from the iliotibial tract and have been considered by Werner Müller by the origin of what he called the anterolateral femorotibial ligament, which originated from the lateral epicondyle and inserting over the Gerdi tubercle. But as we show that the second fracture occurs at the deeper layer, of the capsular layer, and the iliotibial tract is perfectly inserted to the Gerdi tubercle, we believe that the second fracture occurs at the deeper layer, at the capsular layer, so at the level of the anterolateral ligament. The Kaplan fibers probably belongs to the, as I agree that it belongs to the anterolateral complex, and they can be involved in more extensive pivot shift, but only they can be involved later on but it's not the first structure to be involved in the anterolateral rotatory instability in ACL deficient knee, because we showed in most cases the iliotibial tract is perfectly normal or only mild stretched, while the injury usually occurs at the capsule, at the more deeper layer, at the deeper layer, at the capsular layer. So if you pull the bony fragment, only the capsule comes with it. If I show you the videos, I think that the most important part of the anterolateral and also our biomechanical studies. In our study, we cut only the anterolateral capsule. We only split the fascia lata just to have access to the capsule. And by cutting the anterolateral ligament, we found an explosive pivot shift.
So, but when we do arthroscopy in acute ACL MCL injury with a second fracture, we usually from inside the joint we do not see so much of tear or so much of bleeding. There might be hyperemia. So if it is a capsular injury of this severity, why we are not seeing when we are doing scopy in the acute case? I am not talking about the chronic case.
I fully agree with you that arthroscopy is not able to detect injuries of the anterolateral ligament. I fully agree with you. But if you open the joint, so if you open the lateral, you found the injury. It's extra-articular. In some cases, there is a bleeding of the subcutaneous tissue. Sometimes I show you some picture with the bleeding. But from the inside the joint, you don't see absolutely nothing. I agree with you. It's not there is no intra-articular involvement in no cases.
Okay.
You have to have the chance to inspect the anterolateral capsule by an open incision. In this case, we can find that. I would suggest you, if you, someone of you want to start or to inspect, to make an MRI, and to detect, to see the change in the thickness and in the signal on the anterolateral capsule. So you can, in this way, do you avoid to make a non-useful incision of the knee. So pay attention to this area at the MRI. If you have the chance to compare with an affected site, just a T2 image is coronal, a T2 coronal view of the normal side is sufficient, is enough. So you can compare both sides, and if you find a big difference, try to explore to incise the anterolateral capsule and repair the injury. You will find it. I'm sure that you will find.
Okay, so when you order MRI to see this area, do you specify something to the radiologist?
No, nowadays in Italy, some radiologists start to describe changes and pay attention to this area. Nowadays, some radiologists.
Our experience is very poor here.
If you want to, but we teach radiologists in this field. We were teachers of them, and but if you make a coronal T2 views, you can compare both sides, and you will find the difference.
3 millimeter cuts?
Yes.
How many millimeter? Cut.
Usually 3 millimeter cuts, 3 millimeter gantry.
Yes.
Okay.
Yes.
Yeah, 3 millimeter gantry you will be able to see. If you take a 5 or 7 millimeter gantry, you might miss those injuries.
And the two more striking features are disappearance of the genicular vessels,
Right. Okay.
and changes in the thickness and the signal intensity. If you find these signs, there is always an injury of the anterolateral ligament. And
So you see,
do
you see genicular vessel every time in a normal posterolateral corner?
You see the sign, they are clearly seen and with the T2 coronal view.
Dr. Andrea, you just showed one of your Italian football team captain being operated for ALL. So how do you make the decision making of doing whether you want to add ALL, or is it a pre-operative decision or it is an intra-op decision? Suppose you are operating a very elite high level football player who is going to represent an international level. So do you talk to him before the surgery that we are going to perform ALL reconstruction for this patient, or probably your choice?
You probably have experience with the professional football players, both male and female.
Yeah.
And I think that as a surgeon, we should reduce our risk of failure at a premium. So I think that in almost all players of high level players, I perform an extra-articular reconstruction, regardless of the severity of the pivot shift. I must be honest. I think that use of extra-articular reconstructions dramatically reduce the risk of the rate of failure, dramatically. When I perform an extra-articular reconstruction, I'm almost sure that the stability will be okay. In chronic cases, there is no change in post-op rehabilitation.
Right.
In acute cases, if you operate within 7 days, 3 days, 10 days, I recommend to be a little bit more aggressive in rehabilitation if you add an extra-articular reconstruction in acute cases. But if you follow up very closely patients, you have no problem with the recovery of full range of motion and with very, very good stability at follow-up. So when you have a risky patient, athletes, severe pivot shift, adolescents, and hyperlax patient, and especially if you use hamstrings, I would recommend to perform extra-articular reconstruction.
Right. So how many of your patients, which are from 20 to 40 years with ACL reconstruction, will get AAL, ALL in a chronic scenario?
I have no an exact figure about this. However, approximately 70%.
Oh, okay, okay.
More than 50, sure. 70%.
Okay.
Okay. Any other questions?
Roshan, can I ask a question?
Yes, JP, yes.
Yes. So, Dr. Andrea, what is the significance of bony morphology in the rotator stability?
Can you go over again, please? I didn't.
What is the significance of bony morphology in stability of the knee? How to assess apart from the ALL?
I, in actual fact, only consider nowadays, because up to 2 years ago, I didn't consider the bony morphology. I must be honest. Nowadays, I put attention to the slope. But just to possibly increase the number of cases to perform an extra-articular reconstruction. But I, in actual fact, don't pay too much attention to the bony morphology to take my final decision. Only the tibial slope I consider nowadays. But up to 2 years ago, I never considered the bony morphology. I must be honest.
Okay. Any other question to Dr. Before we? Hello. Any other question?
I have one.
Yes.
Hello.
Yes.
Yeah, when answering Dr. Roshan's question, you agreed that the deep part of the Kaplan fiber is a part of this anterolateral ligament complex. And also you agreed that the anterolateral ligament is a separate structure than deep part of the Kaplan fiber. So if the deep part of the Kaplan fiber and anterolateral ligament both contribute to the anterolateral instability when you are getting a explosive pivot shift, we are reconstructing only anterolateral ligament. So how you are addressing simultaneously to other things which are contributing to anterolateral instability?
Because I think that the anterolateral ligament is the most important part of the anterolateral complex. For example, another important part would be the posterior horn of the lateral meniscus. But I do not treat this specific area. If I can suture, I can suture. If I have to do a meniscectomy, I do a meniscectomy. But I never repair the posterior horn if not necessary. So if I don't find any, I think that the most important part of the anterolateral complex is the anterolateral ligament. And so this is what I must repair. The Kaplan fibers can contribute to the anterolateral stability, but they are less important than the anterolateral ligament. Because remember, the second fracture is always related only to the capsular layer. There is no involvement in the second fracture of the Kaplan fibers. that belongs to a more superficial layer that is not involved in the second fracture. If you refer to the second fracture as the signs of what is forced more in internal rotation, there is a mechanism of injuries of ACL tears, then this is the most important part of that contributed to the rotational stability of the knee.
Okay, thank you.
Yeah. I think we should move on to the next lecture. I'll request Dr. Eduardo Monaco. Can you hear me, Eduardo?
Yes, I can hear you.
Yes, yes. You can share your screen, desktop.
Yes,
you can start your presentation. Just open your presentation in desktop and then. So I'm very thankful for Dr. Eduardo Monaco, who agreed to talk on ALL techniques, which is in practice in Rome. And along with, he is one of the partner with
Can you see my screen?
Yes, yes, we can see. Okay. Go ahead, Eduardo. Yes, you can start your presentation.
Okay.
Just mute everyone. So you are unmuted now. And once we finish your presentation, we will take all the questions related to your talk as well as Andrea's talk if time permits us. Yeah, can you hear us? Can you unmute yourself, Eduardo? Just unmute yourself from your screen. Hello. Just unmute yourself, Eduardo. Hello. Eduardo, can you hear me?
Okay.
Just you can start.
Okay, just sorry.
This is a PPT. You can go on down. It won't work on screen. You have to make it from your own screen.
Give me 1 second because I cannot come back to my screen and start back the presentation.
Okay, can you start?
Okay, now? Okay. Now I'm ready.
So you open the presentation in background and then share the screen.
Di nuovo. Okay, here we go.
Okay.
Can you see?
Yes, yes, we can see. Go ahead.
Okay, thank you very much. And thank you for your invitation. I will show you our approach in ACL lesion and associated lesion and how we treat this kind of tears. This is a good video made from our study group, Santi group. You can see why these structures are teared with the ACL at the time of injury, especially ALL. You know that the injury mechanism that lead to an ACL tear is like a pivot shift, is a pivot shift injury. So it's based on an anterior translation and a forced internal rotation of the knee. And this can lead to first a tear of the ACL and then a tear of the anterolateral ligament and capsule and the posterior horn of the lateral meniscus. Sometimes there is a reduction of the luxation by the semimembranous osseous, which can lead to a ramp lesion. This is make easy to understand why is the ACL lesion is rarely isolated. As the professor told you before, we have a great experience with acute ACL injuries and reconstruction, and in the last months, we made this study. We collected all our patients looking at all the associated injuries, and we would to study the risk factors for an explosive pivot shift. We collected all the soft tissue and bony lesion, including medial collateral ligament, anterolateral structure lesions, meniscal, medial lateral meniscal tears. As you can see, we checked all cases, the number of associated lesion we had. But looking at the statistics, at the univariate analysis, we could see that only the lesion of the anterolateral capsule are strongly correlated with the explosive pivot shift. And this is one of the reasons why we mostly focus our technique on the anterolateral aspect and not on the bony morphology and other things. Also, the multivariate analysis showed that the anterolateral structure lesion is the most important risk factor to develop an explosive pivot shift in the patient. So what's our approach in rotational instability in the ACL deficient knee? Usually when we have acute cases, we prefer use a repair technique for the anterolateral side, and even for ACL, as I will show you at the end of the presentation. For chronic cases, we can choose between two different kinds of reconstruction: non-anatomical reconstruction, such as the Cocker-Arnold tenodesis, or anatomical anterolateral reconstruction that we perform using always the ETB as graft. We like the philosophy of repair because, in our opinion, is the best way to add anatomy and biology. With repair, you can have at the end an anatomical repair of the structure which is tiered, and you can allow a biological healing. This is what we do for anterolateral lesion. This was a case report we published some years ago. This was a volleyball player. She had a left knee injury. This was physical examination before surgery in anesthesia. We usually choose if add the lateral reconstruction or not after the physical examination in general anesthesia. In these cases, at lateral exploration, as the Professor Ferretti showed you before, we found a type 3 lesion. So you can see very similar lesion to the lesion we did in the lab in our studies. So it's a complete tear of the anterolateral capsule. And what we do in these cases is a simple repair with stitches of this structure. And what is nice to see is that before fixing the ACL, the pivot shift disappeared by only suturing this structure. This is a video we presented at the American Academy last year, and it was also awarded with an honorable mention. You can see our approach to the lateral aspect of the knee. We use an hockey stick incision. We split the iliotibial band, and this is a technique we described to augment our suture with an internal brace with a tape. So basically, we look at the anatomic insertion of the ELL on the tibia between the Gerdis tubercle and the fibular head, and we fix in this place, as you can see here now, an anchor with our suture tape. First, we drill a socket, a little socket, and then we fix our anchor with a tape preloaded on the anchor. This is basically the same suture you see before, but augmented with an internal brace. So we use the wire coming from the anchor to repair the anterolateral capsule and to reattach the capsule to its insertion on the tibial plateau at the level of anatomical insertion side of ALL. So this is the first part of the technique, which is a anatomic repair of the anterolateral ligament and capsule, as you can see here. It's quite easy to see the tensioning of the capsule and repair of the capsule itself. After that, we look for the femoral insertion of the ELL, which is today agreed for all the surgeon is posterior and proximal to the lateral epicondyle. We check the isometry because when you perform an ALL anatomical reconstruction, it's very important to respect the isometry of the ligament in order to avoid a possible restriction of range of motion in the post-operative rehabilitation. So you need a graft which is tight in extension and slack going in with the knee going in flexion. So the biggest tension should be in nearly full extension when the graft is loaded eventually from the injury mechanism. And so we use the tape, we fix the tape on femur, and so we have this augmentation of our suture by an anterolateral ligament suture tape augmentation. And you can see it's tight in extension, very tight in extension and in internal rotation, and more slack in flexion. And this is a case with a good and quick recovery in the post-operative first week and 1 month complete recovery of range of motion after this technique. For sure, we also use to repair the second fracture, as you see before. Here you can see what we do. This is a repair with an anchor. We put an anchor on always on the tibia, on the lateral aspect of the tibia, and then we fix the bony and capsular fragment. This is another case. Again, we put an anchor and we fix the anterolateral capsule. So we fix the bony fragment, but also we suture the capsule. Again, before ACL fixation, you can see reduction of the pivot shift by only suturing the anterolateral capsule. Another case, again, the ETB is intact, and also its insertion on the Gerdis tubercle is intact. And we performed, in this case, a simple suture of the fragment and of the capsule by simple stitching suture, as you can see here. We change a little bit the technique for repair on the base of the bony avulsion fragment dimension. Sometimes we use a simple suture, sometimes we add an anchor, and when the fragment is bigger, we can use even a screw. And again, you can see reduction of the pivot shift just after anterolateral repair and bony and second fracture repair. And this is our publication, as the professor told you before. We did some cases in the last years, and we reached good results after suturing the bony avulsion. This is our proposed technique for anterolateral ligament anatomical reconstruction. We use always the iliotibial band because it's very familiar for us, coming from the Cocker-Arnold technique. This is our technique. Always is an open technique, hockey stick incision. We harvest 5 millimeters strip of the ETB, long about 16 to 18 millimeters. We leave the graft on the Gerdis tubercle. Then we look for the 2 insertion site of the ELL on femur and on tibia. As I told you before, we carefully check the isometry of the graft. We don't want a graft which is tensioned in flexion. And then we use our graft. We loop our graft and we fix it first on the femur. And this is the first non-anatomical bundle coming from the insertion on the Gerdis tubercle to the epicondyle. And this is the reflecting bundle, the second bundle, that we fix on tibia at the insertion side of the ELL. So at the end, we have a V-shaped graft reproducing the ALL on the anterolateral aspect of the knee. And this is the non-anatomical procedure we use mostly, and this is the Cocker-Arnold modification of the Macintosh technique. Is a little bit bigger, is 1 centimeter strip of the iliotibial tract, which is detached proximally. Then we look for the lateral collateral ligament. We isolated the lateral collateral ligament and we pass our graft, our ETB graft, under the ETB, and we reflect it under the ETB, and then we fix our graft with the tibia and external rotation. We fix the graft with the lateral collateral ligament and with itself, and finally we fix it on the Gerdy's tubercle with absorbable stitches. But as I told you, sometimes also the medial collateral ligament is involved in the injury. And as you maybe know, the famous triad of O'Donoghue, so the lesion of the ACL and of the medial collateral ligament and medial meniscus. But we did this paper where we look at that also the anterolateral capsule is injured, so the triad is really a tetrad. And what is our approach? Again, when you have a big tear of the medial collateral ligament, we usually do stress X-ray. This is an acute cases with a big lesion of the medial collateral ligament. This is the superficial part, and this is the deeper layer of the meniscal femoral layer of the medial meniscus that we repaired in acute cases. And as I told you here, we had also a type 3 lesion of the anterolateral capsule that we repaired with, again, as I told you, with the simple stitches, with the retentioning of all the anterolateral aspect of the knee. This is the 1-year follow-up of this patient. We see last week with a good stability, excellent stability in medial stress, and Lachman and pivot shift are all negative. So we treat medial collateral injuries when we have a big instability and an opening more than 10 millimeters in the stress X-ray. This is another recent case. Again, a big medial collateral ligament lesion. Again, we explore in an open fashion with approach by an anteromedial arthrotomy. We found a repairable ACL. So we opted for all repair technique. So we repaired the ACL, the MCL, and the lateral capsule, as I will show you. You can see here anteromedial arthrotomy. Then we perform a posteromedial arthrotomy. Here you can see the big lesion of the deep meniscotibial band of the medial collateral ligament that we fixed, we sutured with using anchors to the bone. For sure, the deeper part of the MCL is the most important biomechanically, so it must be strongly fixed to the bone with anchors. And then we also repaired the superficial part of the MCL. As you can see here, good stability. But as I told you, usually the triad is a tetrad, so we also explored the lateral aspect of the knee, and we found again a big stretching of the anterolateral capsule that we fixed again with an anchor, refixing the capsule to the always to the anatomic insertion of the ALL on the tibia by stitches. And finally, by performing an out-in drill on the condyle, we we repaired also the ACL, so an all repair technique. As you can see, we use always an out-in technique, just even for both for ICL reconstruction and for ACL repair. This is the passing wire. We pass the wire of the ACL and we fix it with a plate on femur, as you can see here. This patient had a little fibrosis in the postoperative period, so we reoperated the hair 40 days after surgery, and this is the appearance of the repaired ACL at 40 days by arthroscopy. You can see a completely healed ACL, and this is a very curious and interesting second look check of an ACL repair. But as I told you, and also Professor told you, we work in a hospital with an emergency department, so we can see a lot of acute ACL tear and injury to the knee. And in the last year, we started a little experience with ACL repair also. But we, as I told you, we used to address the ACL and also associated lesion. And this is another nice case we presented at the academy, where you can see a type 2 ACL tear with a good remnant of the ACL that we could prepare for a repair. But the patient had also a second fracture. So again, what we did is a whole repair technique. So we basically repaired the ACL, in this case by arthroscopic technique. Is the same technique I showed you before, but in an arthroscopic fashion. You can see at the end, the ACL seems to be normal ACL, but is just repaired. And as always, even in this case, we fixed the second fracture with the use of an anchor. This was the post-operative clinical examination with the Lachman and pivot shift negative. The patient did the MRI showing a good healing of the ACL at 5 months. At 5 months, she had a very stable knee with a negative Lachman test and negative pivot shift test, complete recovery range of motion, and a 0 millimeter difference at the KT 1000. So a very, very good and stable knee. And in recent months, we had 2 similar cases with the second fracture and the ACL. Here you can see even the hemorrhage and subcutaneous coming from the joint from the second fracture. You can see this was a very acute cases, maybe 5 days after injury. We found again a repairable ACL. We use always the same technique. We prepare the remnant with non-absorbable high resistance fiber wire suture. We usually use 3 portals to manage the wires for the repair of the ACL. Then we also explored the lateral aspect of the knee to fix, as we usually do, the lateral, the second fracture. This is our technique for the femoral tunnel drilling. We put the wire at the level of the femoral stump in case we repair the ACL, and we do not debride anything on the lateral condyle to allow the healing of the ACL to itself on the femoral stump. Then we pass the wire from in to out. This is the lateral exploration. As you can see here, after splitting of the ETB, it's possible to see in another layer, in a deeper layer, the bony fragment of the second fracture. Again, you can see that the lesion is in a completely different layer In this case, we put an anchor to fix the fragment. And this is the second fracture repair by mattress suture. And final retention even of the capsule. And again, we fix the ACL by a plug on femur. And this is the final check of the repaired ACL. This is another case, it's always ACL tear and second fracture. You can see the bone bruise, the MRI. And so we did again, repair of the ACL. This was a type 2 lesion with a good remnant again. Quickly, I will show you again our out-in drilling technique. We free the passing wire. We fixed, we passed through a cannula, the ACL wires from in to out. Again, we found the second fracture and we fix it with a screw, with an anchor, sorry, and with suture. And so the technique is always the same. We use the plate and we fix on the femur, and this is the repaired ACL at the end. Thank you very much from Rome and from Italy.
Very nice. Excellent. So ACL repair work.
Yeah, it was a very nice talk.
I hope you can understand our approach and our different techniques, because our.
So do we have any question? Dr. Nishith, Rajkumar, Atik, Samir, Sandeep?
For ACL repairs,
Vivek Pandey.
For ACL repairs, I would like to ask them long-term follow-up, how much they are having for that, and whether they have studied the MRIs for this.
Monaco, he wants to know what is the long-term follow-up for ACL repair and how did it behave? Is the healing is complete after ACL repair, or you have a residual laxity?
No. We have a good, very, very good preliminary results with no cases of failure, no residual laxity. A great feeling coming from the patient. And we start 1 year and a half ago. So we have our first cases that are 1 year and a half follow-up. We are following our cases by serial MRI at 1, 3, 6, and 12 months postoperatively. Our first paper is coming out on an Italian journal, and it's, even if preliminary results, we have a great feeling about this technique.
Yeah.
What are your MRI reports says?
MRI is very good. It show a very intense signal of the ligament, and maybe better than the signal of a reconstructed ligament at the same postoperative timing.
Andrea and Monaco, I have a question for both of you. You have been doing this ACL primary repair along with ALL repair. So does the ALL healing pattern is similar to the healing pattern of ACL? Because what has been taught to us in our graduate, the first medical year, that it doesn't heal. The natural tendency of the anterior cruciate ligament being an intra-articular ligament, it doesn't heal. But here we are again going back to the primary repair technique of ACL. So the collagenization which happens, is it same like what we get it in ACL reconstruction, or it is a fibrous tissue which forms a band?
Quickly, I will reply before leaving the talk to the professor. For sure, they are two completely different ligaments, but there are some recent papers showing that maybe even the ALL is not able to completely heal alone if you don't treat it. So it's not true that the ALL can heal without treatment. And concerning the ACL, I know the literature and that most of the paper report that it cannot heal, but we strongly believe that if you repair in the very first days after injury, you can give to the ACL of its ability to heal with itself. So this can help the ligament to heal.
Yeah. Our experience is also similar. I think that we have to repair this ligament if it is repairable in the initial stages, and it heals. But let me ask you that how many times, if you repair the ACL, do you do internal bracing?
No, on the ACL.
Not on the ACL. Okay.
No,
and
no.
every time you do ALL when you do ACL repair?
Yes. Absolutely yes. Absolutely.
Okay. So even if there is no lateral injury, you will always do ALL?
Lateral injury.
No, when there is no lateral injury, we do not perform any additional procedure. In our series, Eduardo told you that we perform about 50 cases of ACL repair, and I think that in this series we have only 3 or 4 cases without additional procedure, without ALL repair. Because in actual fact, in 90% of cases, there is some extent of lateral involvement.
So why can't we do ACL repair in the old cases where it is repairable or where the stump is good?
We must be, till now, up to now, we did not perform repair in high level players, only in amateur athletes. Yes, because we must be prudent about this. We cannot risk too much a failure in professional athletes till now. But I think that if you have the chance, if our results will continue to be as good as they are now, I think that it would be possible to repair also in professional athletes, because avoiding harvesting any type of graft, either hamstrings or patellar tendon, would be beneficial for athletes.
Right.
Roshan. So I think that in the future.
Yeah, Rajkumar. Yes, Rajkumar.
I think the future indications for repair can increase, because with some technical skills, with some technical tricks, probably avoiding any debridement of the femoral stump. We must leave all the femoral stump intact. This is our philosophy.
Yeah. So because I have been doing for 5 years, and I have 5 years follow-up now. So 5 years follow-up now.
Yes.
Of the ACL femoral levels and repair.
Yeah.
So it will be interesting to see your paper.
I'm sorry. You can. If you follow the Journal of Orthopedics and Traumatology,
right,
is in English, of course. You can. I think in the next few weeks, our first paper with the MRI serial studies will be shown, and is an open access. Is an open access journal.
Okay, that's good.
You follow Journal of Orthopedics and Traumatology by Springer.
Okay.
By Springer.
Okay.
Professor, can I ask you a question?
Yes, Rajkumar. Yes, please.
I understand you have done ACL repairs, and there is an preliminary result, which I guess is less than 2 years. Am I right? Okay. If it is less than 2 years.
Less than 2 years, yeah.
Yes. I must congratulate you for the good results that you have got so far. I must congratulate both of you. But if you can elaborate on, within this short period of time, what has made the ACL to heal so much better? Is there anything that you do differently to enhance its biology of healing? We know that we repair the ACL, but we also should know any special trick that you have to enhance the biology of healing of this kind of a repair.
I think that there are several studies on the process of healing of the ACL, and almost all authors agree that the ACL would have the potential of healing, but this potential of healing is impaired by the intra-articular behavior and the intra-articular environment, because there is the synovial fluid that wash up the clot of the platelets, from which the healing process would start. But if you had the chance to reapproximate the stamp early, the growth factors can be released and the potential of healing enhanced by the surgery, by the early surgery. We don't know now if the results, the long-term follow-up will confirm the preliminary results. Is a sort of a challenge, but by strictly following some criteria of repair, we think that there is a chance for a repair of a good healing of the ACL. As you know, we just speak about this 5 minutes of an hour and a half presentation. We are very prudent about this. However, this is a field that is one of our now main topic. And if we are continuing after the first 10, 20, 30 cases to do a repair, it means that we are nowadays confident in this technique. Because believe me, it's not easy to have 50 cases of repair in 1 hour, in 1 year and a half period time. So yes, we are confident. Our results are encouraging. I think that in the last 1 hour, 1 year and a half, we have only less than 20% of cases where we evaluated the ACL non-repairable. In 70 to 80% of cases, we evaluate the ACL repairable.
So, Professor, if I have to understand, your first to go treatment in an acute injuries is repair.
Yes.
Correct? Now, in such a situation, if you repair, you also would go ahead and repair the anterolateral ligament, or you look for at least to repair. Yeah. So, in all your cases that you have repaired, do you think that the ALL repair or the lateral repair that you do for a second fracture is protective for the ACL repair, or it enhances the repair?
Yes.
Do you want to infer like that?
Yes.
Yes.
We
also want that.
We believe that the rotational instability is a comprehensive problem. It's not just related to the ACL. So yes, you have to comprehensively approach this injury. You have to treat all the lesion, both ACL and anterolateral. In this case, we have the best chance to have a good outcome. The best chance. I think that you can have the chance also with the isolated ACL repair or reconstruction. But if you want to increase your rate of success and reduce the rate of failure, I think that adding an extra-articular reconstruction can give you more chance of success.
Yeah.
Acute repair, I understand. Roshan, last question.
Yes, yes.
Acute repair, Professor, I understand is before 3 weeks or after 3 weeks?
What is the time limit of your repair?
For 2 weeks we use, not 3.
We prefer 2. we just, I think that in this series, we have only one case of repair after 3 weeks.
So,
I
Professor,
think 1 or 2, no more,
Yeah.
because
Yes.
we prefer to treat as soon as possible.
Yes.
Kumar,
Professor,
after 4 months.
Professor, if
Okay.
I may ask,
And it
going
is
on
good.
to professional athletes, if you were to go on to professional athletes later on, who have to return early, so would you, in addition to doing a repair and an extra articular procedure, would you consider some form of internal bracing?
Personally, I a little bit worry about the possible effect of stress shielding. I think that in order to allow the fibers to properly heal and reinforce, they need to be stressed. I fear about the stress shielding of the internal brace. This is my concern about the use of internal brace sometimes, because I fear about the stress shielding. And in the remodeling phase of the healing, we need the fibers need to be stressed enough. So I'm a little bit concerned about this. I'm not sure, but is my concern using the internal brace.
Professor, there are few questions which are come out on YouTube. Actually, we are live on YouTube. So I'll just read a few questions if you could answer them. There's a question from Dr. Arun Gupta. He is asking Dr. Ferretti if can we take home the message as Sigon type 4 needs a surgical repair and Sigon type 1, 2, 3 can be managed conservatively?
Type 1, 2, this is a good question. The problem is, if we believe that an ALL injury can heal spontaneously without any surgical treatment, we should see that in the follow-up period, the rotational instability as observed at the time 0, at the time of injury, would decrease. This is not what actually happened in the reality. Usually the instability rotational instability tend to increase over time, not to reduce. So if with time the ALL would repair spontaneously without treatment, it means that with the time the rotational instability, the pivot shift would decrease. This is not what happened in reality. In actual fact, usually with time the rotational instability increase, not decrease.
Dr. Antao has asked few questions. Dr. Nicholas Antao.
That can heal spontaneously.
Yeah, Dr. Antao has asked few questions. He wants to ask, females are reported with lateral condyle hyperplasia. Do you see such patients with ALL instability with lateral condyle hyperplasia, and how do you address that? And there is another question from Dr. Antao, like similarly what you see ALL injury, do you have something known as anteromedial laxity also? Because pivot is the anterolateral instability. Do we have the similar mechanism for anteromedial laxity when you see a pivot or reverse pivot?
La prima sul condaglio non è un fattore
No,
di rischio, secondo i nostri dati non c'è
in our experience, the factor affecting rotational instability in the study that was presented by Eduardo at the beginning of his presentation, in actual fact, there was not a factor affecting rotational instability. The main factor was the injury of the anterolateral ligament. And in any case, I don't think that any kind of bony alteration, bony morphology should be corrected by the surgeon. So we have only to address the soft tissue, ligaments, and reinforce the reconstruction as much as we can, but don't try to change the bony morphology because it would be a disaster for the knee. And the other question was about the anteromedial instability. The anteromedial instability is a part of the triad, the unhappy triad. And I showed that in actual fact, the medial side of the knee can heal within certain limits, because if you have a severe anteromedial instability, you have to treat it surgically, as Eduardo showed in when there is an opening higher than 10 millimeters. I think it's better to make sure to do a suture also in the medial side. However, remember that in our experience, the unhappy triad, the injuries of medial collateral ligament, is always associated with the anterolateral instability and the injury of the anterolateral aspect of the knee, which is more important for the stability of the knee than the medial side.
Another question which has come from Dr. Antao is the blood supply to the lateral side of the knee is much more better than the blood supply for the medial side of the knee. So don't you think this ALL, if it is torn, will have a high healing potential if you conserve them?
No, I think it's exactly the opposite. I think that the healing potential on the lateral side is lower than the medial side. And I can say that even in case of severe of accurate repair of the anterolateral side, the quality of the tissue is lower than the medial side. Then I think that the suture, the primary suture of the anterolateral ligament is less effective than on the medial side. Sometimes probably an augmentation with an extra-articular reconstruction would be needed also, even if in acute cases. We prefer to do a repair, but sometimes when we found a tissue of very, very poor quality, we also in acute cases, we perform a lateral reconstruction to augment the repair. Usually in 80-90% of cases, we perform only a repair. But sometimes when we found a very massive involvement of the lateral, anterolateral capsule and ligament, we perform also a reconstruction. It's almost like the posterolateral involvement when there is a PCL injury. You know that some authors recommend also to augment the repair with a posterolateral reconstruction at time zero, immediately. And probably would sometimes I would recommend also in anterolateral severe disruption.
So when do you advise the augmentation? At what type of tear? 1, 2, 3, or 4? Type 4 ALL tear you need augmentation, or even in 1, 2, 3 type of?
Usually in type 2 or 3.
Or 2 or 3. Okay. Any other question before we thank Dr. Andrea for his wonderful talk? Nishith Shah, Sheikh, Ranjit, Rajkumar, Atik. Any other question? Okay. If there is no questions from any of the panelists, Dr. Andrea, let me thank you. It was a wonderful, wonderful session. It was a really.
Oh, sorry. Can I ask one? Sorry.
Nishith, yes, quick question before we end the session.
Yeah, sorry. Professor, the thing is that the ALL was discovered recently for us, right? But we used to, I used to do the Larson procedure for the lateral repair for a very, very long time. As I told you that in India, everybody sits on the ground and everybody sits cross-legged or in the lotus position. So we have to have a very good lateral stability. So how come the Larson procedure has worked in our hands for such a long time?
Probably you have a bigger experience than us on this particular kind of instability. usually the Larson procedure we use for the posterolateral instability rather than for the anterolateral. We perform few cases of posterolateral instability. So even we should consider also that the technique we use, the Cocker Arnold and actual factor retention, also the lateral collateral ligament. So there is a very, very mild effect also on the posterolateral. However, I think that probably you have more experience than us on this particular situation.
Okay, so how do you differentiate between the anterolateral and posterolateral when you do pure shift?
Because of the varus stress and the IL and so.
Okay, right.
Yeah, thank you, Dr. Andrea, for wonderful talk and wonderful explanation. Especially Eduardo, your video quality was very high quality. The explanation of videos were fantastic. It was a really eye opener for us. That
the first video was very good.
Yeah, ALL repair along with ACL repair was a really eye opener. I never thought of doing such kind of procedure in clinical life. And I'm very sure, Andrea, with your today's talk and Eduardo, with today's presentation, more and more people will be fascinated to go towards ACL repair and ALL repair rather than going for a delayed reconstruction, which is a norm in our country. So thank you very much. I hope
thank you to all of you.
Roshan, for very interesting.
Contact us for any further information, question.